Hello everyone, it's Schematic Matt, and today we're going to talk about ethics and legal issues for USMLE exam. This video is for dedicated and preparation period, and I want to warn you, this video is not very visual and we're going just to look and listen to the high yield points of the text. So this is preferably for like listening before sleeping or while driving, and yeah, I just warn you. Let's start. Let's start from the general principles. One of the important general principles is respect for autonomy. Healthcare providers are obligated to honor the individuality of patients and respect their choices. So, for example, when there is a pregnant woman that comes and refuses cesarean section, and we need to respect that. This is called the principle of maternal autonomy. So as long as the mother has capacity, she has rights over her unborn child. Next principle is beneficence. Physicians have a responsibility to act in the patient's best interest. So let's try to understand. Sometimes the respect for patient's autonomy may conflict with beneficence. So the one that we just discussed, the prior respect for autonomy, can conflict with the beneficence, like acting with patient's best interest, which is acting of patient's best interest. So what that means? In general, if a patient is mentally competent, respect for patient's autonomy supersedes beneficence, even if we, the physicians, and we believe that patient is not acting in his or her best interest. So what that means? For example, we all know transfusions to a Jehovah's Witnesses. That is the beneficence, but they want to not be transfused. We need to respect the patient's autonomy. We think that the transfusion will help this patient, but the patient does not want to be transfused the blood. So we need to respect the patient's autonomy. The autonomy supersedes beneficence. Next principle is non-maleficence. Do not do harm. So for example, a surgeon should not do or perform a procedure if the physician thinks that patient will not live intraoperatively. Next is justice. Justice has the intent to promote fair and equal treatment for individuals within the population. Next, let's talk about informed consent. Informed consent is voluntary acceptance of a medical intervention by a patient after adequate discussion. Adequate word is very important with the physician about the nature of the intervention along with its indications, risks, benefits, and potential alternatives, including no treatment. Remember, alternative is no treatment is alternative too. So we're going to talk about this very thoroughly a little bit later, but let's talk about that patients may change their mind at any time. So they can give you the consent, then they can change their minds. Okay, informed consent is required for significant procedures except for the following. These are very important points. The exceptions are: emergency treatment is required. For example, there is an unconscious patient that undergoes cardiac arrest, or is unconscious and you need to do like blood transfusions, something that will help that person to stay alive. So that is the emergency. It doesn't matter if the family members or even if you don't have anyone that you can help the patient, and you should help the patient during these emergency situations without informed consent. Next, patient lacks decision-making capacity. Consent is still required. In this case, when the patient lacks decision-making capacity, you need to have the consent, but the consent must be obtained from a surrogate decision maker. Okay, you need to find who is the surrogate, and then you need to have the consent. And let's talk about the minors. Minors generally require surrogate decision makers until they demonstrate adequate decision-making capacity or are legally emancipated. We're going to talk about what we understand when we say legally emancipated too. So when the physician needs to have a discussion, and what should the physician talk with the patient, then the patient, if understands, if has capacity decision making, gives the informed consent. So informed consent involves giving the patient information about the following: diagnosis, so his or her condition and what it means, so what that patient has; prognosis, so the prognosis can be bad or good, so the nature cause of the condition without treatment. What will happen with the patient if the patient will not take medications, the operation, so procedures that's without treatment. Then we need to talk about the actual treatment, what we are proposing. So description of the procedure and what the patient will experience. And then, of course, all the procedures and medications, they have risks and benefits, and of course, alternative treatments. So what can the patient do if he or she does not want to do this treatment? And additionally, no treatment is alternative treatment too. A brain death is the irreversible loss of the brain activity and is equivalent to cardiopulmonary death. If a patient is brain dead, no consent is needed to stop therapy. 2 physicians are required to perform brain death exam to legally declare a patient brain dead. Let's talk about the minors. In general, we call minors who are below 18 years old of age and cannot consent for their own medical treatment and require parents or guardians to consent on their behalf.
So this point is very important. One parent is sufficient as long as that parent has custody. So, for example, if 2 parents have shared custody and one parent says that yes, you can do that procedure or you can give that medication, and other parent does not agree, you can give and do that procedure, because one more time, one parent is sufficient to give consent.
So we need the consent for minors, except, of course, we always have exceptions. Exceptions are life-threatening emergencies when parents cannot be contacted. We already talked about the emergencies. We already understood that. Next, legal emancipation. So this is especially for your examination purposes. This is very important. You need to know who is legally emancipated. Emancipated minors do not require parental consent for medical care. Minors are emancipated if they are married, are in the armed services, they are serving in the army, are financially independent of the from their parents, and have obtained legal emancipation. Additionally, and we count minor emancipated when that minor graduated the high school. Next, sexually transmitted infections and substance abuse treatment. Of course, this varies from across the United States, from state to state, but especially for examination purposes, if the minor wants to talk about the contraception, pregnancy, abortion, or sexually transmitted infections, that treatment, and asks you to not disclose that to parents, you do not disclose, and you, even if parent asks you to do so, you do not disclose this information. Of course, this varies from state to state, but for examination purposes, most of the time you do not do that. And refusal of treatment. A parent has the right to refuse treatment for his or her child, as long as those decisions do not pose a serious threat to the child's well-being. So, for example, The physician thinks that immunizations, the prophylactic immunizations, they are very, very important, and they are serious threat to the child's well-being. But mother or father, the parents, both of them, they say no. So in this case, so the physician, of course, this case you should not immunize patient, because if it is prophylactic immunization, that is not considered a serious threat. But if that, for example, something happened, if you don't give that medication, the patient is most likely will die soon, or will go to cardiac arrest, and that is emergency. We already talked for emergency cases, we don't need the consent. But if you think if it is not emergent situation, you need a court order. If parents, they're not saying yes, and it is not it is non-emergency situation, you need a court order. For example, a physician provides blood transfusion to save the life of a 6-year-old child despite parental request to withhold such a measure. So blood transfusion is life-saving procedure, and 6 years old is a minor. Parents are refusing to do this procedure. But if you do not do this procedure, the patient's life is in danger. So you need to do that. Let's talk about competence and decision-making capacity. These two words, they're very similar. They're like they start with C, but they are different. So competence is a person's global and legal capacity to make decisions and to be held accountable in a court of law. So competence is assessed by the court. This is very important, court, because we're going to talk about decision-making capacity, which is assessed by the physician. So physician cannot say this patient is competent or not, but physician can say this person has decision-making capacity or no. Okay, incompetent patients again need to be assessed by the court. Decision-making capacity is the ability of a patient to understand relevant information, appreciate the severity of the medical situation and its consequences, communicate a choice. So they are saying, I understand, when you're explaining all the points that I already talked, the diagnosis, the alternative treatments, the prognosis and everything. So you ask questions, the patient says, yeah, I understand that this procedure has these risks. I understand that if I don't do this, this will happen. I understand that I can choose from this. So everything is very logical, and it is easy to communicate with the patient, and this is assessed by the physician. Decision-making capacity is best understood as varying with the complexity. So we need to understand that there are some medical decisions that they are not in there. Some of them are very complex to try to choose, and some of them they are not very complex. For example, when we're talking about a serious operation, for example, neurosurgical operation, I don't know. These decisions, they are not very easy to choose. If someone says we need to transplant your liver, and at that time maybe patient starts to give more questions, or he or she needs to think about more. It doesn't mean that that patient does not have decision-making capacity. Okay, it varies. Or for example, when the patient has a mild headache, you're just asking, do you understand, like, do you want a painkiller? Yeah, I can. I understand that this painkiller can like affect my digestive system and or cause any other adverse effects, but I want it. So that is very different. So it is important how complex is the decision. In general, patients who have decision-making capacity have the right to refuse and discontinue treatment. For example, if Jehovah's Witnesses can refuse being transfused blood products. A patient's decision to refuse treatment can be overruled if the choice endangers the health or welfare of others. This is important. For example, a patient that has active tuberculosis (TB) must undergo antibiotic treatment because it is public health threat. Next, end-of-life issues. The most common written advance directives are living will and power of attorney. Living will is a written document which addresses a patient's wishes to maintain, withhold, or withdraw life-sustaining treatment in the event of terminal diseases or a persistent vegetative state, when the patient has lost the capacity to make decisions. So that is a document where I'm stating, for example, for me, I'm the patient. I'm stating what I want to be done when I lost the capacity to make decisions. So during the terminal disease. For example, DNI orders are based on the patient's preferences regarding CPR and intubation only. So if it is DNR, it means do not resuscitate. But it is only if it is only DNR, it means you can intubate. Okay. Patients can refuse all non-palliative treatments or specific therapies, for example, CPR, intubation, antibiotics, feeding tubes. A living will overrides the wishes of the family. So family member, they come here and they say, please do everything, intubate, do the CPR and everything. But the patient's living inside the patient's living will, it says, do not do that. You are not doing that. Power of attorney for healthcare legally designated document. It is a document that grants authority to a named person. Actually, it is a document that grants the authority to the person who is that. That is how we can distinguish two from each other. Who is healthcare decision maker if a patient lacks decision making capacity. So I'm saying someone will choose for me, make a decision for me if I lost my decision-making capacity. It is more flexible than living will, and surrogates should make decisions consistent with the person's stated wishes. For example, I'm saying someone that I don't want to be intubated. So when I lost my decision-making capacity, the surrogate should not, for example, the surrogate loves me very much and he or she wants me to be intubated and that my life was saved and everything. But if when I said, when I had the capacity, decision-making capacity, I said I don't want to be intubated. So the surrogate need to state my wishes. It doesn't matter what he wants. And no living will. If no living will or durable power of attorney for healthcare does not exist, decisions should be made by the close family members. This is the next of kin. This is very important to know the order. First, next of kin is spouse. Not the first, of course, we already talked, that is the living will and power of attorney, but next will be spouse, then adult children, then parents, then adult siblings. And after that, if we can't find anyone from here, then friends. But one thing that we need to remember, for example, the patient lives 10 years with one of his or her friends, and like they share everything. They have the same refrigerator, same bathroom, same rooms, and everything, same kitchens, everything everything is the same. But the patient has like mother, for example, that he or she did not see like 10 years. Of course, the friend's opinion who says that the patient stated this, wanted this, has higher value than the mother comes and says, I want my daughter or my son to be intubated and resuscitated. Ethics committee or court orders can be helpful when the patient lacks capacity, has no proxy or advance directives, so has nothing that we talked about this, and there is disagreement among family members. So it is not something emergency. It is there is a disagreement between the family members. Sometimes this order can be, for example, they will be the adult children or other children between these two children. So then we can ask ethics committee, okay? And sometimes it can be disagreement between family and healthcare providers too. Next important high-yield point is withdrawal of care. Patient and their decision maker have the right to forego or withdraw life-sustaining treatment. Nevertheless, physicians should seek to understand patients and their reasons for refusing beneficial treatments. What this means is that patient can say that I don't want to, I want to stop the life-sustaining treatment. I don't want to be like treated, and that's all. Okay, what is your next step? You need to the first step is to understand why patient wants so, why patient thinks so. Okay, and what patient thinks about these treatments. So what made the patient to think that he does not want to be treated or to be used that medication or that procedure. No ethical distinction is made between withholding a treatment and withdrawing a treatment. Withholding is not giving the treatment. Withdrawing is when you gave it and stopped it. Because a patient may choose to refuse an intervention either before or after it is initiated. So you can start it, but you can stop it. Okay, the patient can decide to stop it. This can include ventilation, fluids, nutrition, and medications such as antibiotics. Hospice care is focused on palliation of symptoms for patients with a prognosis of less than 6 months of life. This is important. The red one is important. The focus is on patient management, quality of life. If the intent is to relieve suffering and medications administered are titrated for that purpose, it is considered ethical to provide palliative treatment to relieve pain and suffering even if it may hasten a patient's death. Principle of double effect. For example, you can prescribe high dose of opioids, and when you know, for example, the patient has to live less than 1 day, but we all know that opioids can suppress the respiration and hasten the death. Let's talk about euthanasia. Euthanasia is the administration of the lethal agent with the intent to end life. It is illegal in all states. Patients who require euthanasia should be evaluated for inadequate pain control and comorbid depression. So if someone wants to use this choice, so we need to understand maybe the patient has very severe pain, maybe or depression. So that is very important. Alternative treatments are if a patient is interested in alternative and non-traditional treatments, for example, herbal teas or herbal supplements, the physician should obtain more information. You need to ask the patient, you need to go and read about that herbal treatments, okay? And you need to be interested. While the physician should provide as much information as possible, if of course you're familiar with that, he or she should not dismiss the patient. Like physician cannot say, if you want to use that herbal supplement, I'm not going to treat you. You cannot say that. Disclosure. Patients have a right to know about their medical status, prognosis, and treatment options, which is full disclosure. They have the legal right to obtain the copies. Only the patients, not the family members. A patient family cannot require that a physician withhold information from the patient without the knowledge and consent of the patient. So a family member cannot come to you and say, please don't say the information, he will feel bad. At first, you cannot, of course, you need to try to understand why the family member thinks that is the next step. Ask why the family member thinks so. And here we can see it is stated here that should explore why the family member does not want the diagnosis revealed. A physician may withhold information only if the patient requests not to be told. So we will see again when we can disclose the information, but disclose to other people and disclose to the patient is different. So if the patient says, I don't want to know what the biopsy results are, you're not saying them. Of course, you ask why, then you're not saying them if the patient says no. So this is called the disclosure. Would cause when the disclosure can cause a severe and immediate harm to the patient. You are not saying we are not disclosing. This means to therapeutic privilege. Let's talk about medical errors. Physicians are obligated to inform patients of mistakes made in the medical treatment. So for example, the operation, there was a medical error, you need to say that. It is not appropriate for the physician to blame another physician for a medical error without obtaining additional information from the original physicians. So you never can blame your colleagues, right? You need to try to contact them, talk with them, understand what happened. One of the largest contributors to medical errors is failure to communicate during sign-outs and handoffs. These are very important. The best way to avoid communication breakdowns is to implement checklists for handoffs. About clinical research. Physicians are obligated to inform patients considering involvement in a clinical research protocol about the purpose of the research study and the entire study designed as it will affect the patient's treatment. This includes the possible risks, benefits, and alternatives to the research protocol. An informed consent, of course, when you're doing clinical research, you need informed consent form approved by the Institutional Review Board and must be completed completed for participation in any clinical research protocol. Newly deceased patients may be used for training healthcare providers, but we need to have permission from the family or patients prior to death. Prior, not after. Confidentiality. Information disclosed by a patient to his or her physician and information about a patient's medical condition are strictly confidential and should be discussed and accessed only by those directly involved in the patient's care. A patient may waive the obligation of the physician to protect confidentiality. For example, the patient can say that my work employee or insurance company will call you, please disclose the information. And patient can say that in written form and verbal consent is valid. It should preferably be written, but it can be verbal. The physician should disclose only minimally necessary information. So the patient says, if my employer calls you, yes, I'm giving the consent, so you can give the information. But it doesn't mean that we need to talk all the medical history. We need to give minimal necessary information. So once again, break confidentiality only in the following situations. The patient asks you to do so. Child harm is suspected, which is mandated reporting. The court mandates you to do so. You must fulfill the duty to warn or protect if a patient says that he or she is going to harm someone or himself or herself. You have to tell someone, the authorities or both. The patient has a reportable disease. For example, gonorrhea, syphilis, and we're going to talk about reportable diseases in another video. The patient is a danger to others. For example, there is a blind or has a person that has seizures. That person is driving or is a bus driver or a bus driver that it has a paranoid schizophrenia. They should be assessed. And it is ethical and legally necessary to override confidentiality in the following situations. It is ethically, legally necessary to override confidentiality in the following situations. So basically, this is stating the same things in different words. When patient has intent to commit a violent crime. This is Tarasov's decision. You can search. There was a person that says to his psychiatrist that Tarasov is a name of a girl, and the patient was obsessed, was in love with the Tarasov, and the patient disclosed that he is going to harm her. but eventually this girl was not aware of that, and eventually the patient harmed the terrace. And then the parents of the girl, they went to court and said that the physician, the psychiatrist, should have warned the girl, so that the patient is going to, that the patient said that he will harm. And patients that have self-harming risks, and when the child is harmed or neglected, and elder is harmed and neglected. Reportable infection diseases, which are HIV, sexually transmitted infection, tuberculosis. Duty to warn public officials, so at first we're speaking with patients, we're encouraging them to speak with their partners or people that they live, and I'm telling about the tuberculosis, of course not the sexually transmitted infection, but when we need to warn someone, it is public officials and identifiable people who are at risk. It is normally best to encourage patients, again, one more time, let's say that patients themselves to inform the sexual contacts who are at risk for contracting the illness. Gunshot and knives, I think this is like universal. Every country has this rule that if you have the gunshot or knife wounds, this should be notified to the police. And the patient is a danger to others. For example, impaired automobile drivers, for example, if they have seizures, general seizures, and they need to be seizure-free at least 3 months if they want to have driver license. So here it is stated the same thing, that we can disclose it when the third party can be harmed, the harm is significant and probable, and disclosure will help to prevent or mitigate the harm, or other measures such as convincing the patients to self-disclose have failed. Potential signs of elder neglect and harm, it can be cuts, bruises, pressure ulcers, and burns. Uncommon fractures, so we know that elder people, they have osteoporosis and they can have hip fracture, which is common fracture actually, but uncommon fractures can show us signs that is potential sign for or neglect or patient elder harm. So, and then malnutrition or dehydration can be signs, and genital injury or infection, and evidence of poor caretaking. And let's talk about the child harm. It can be history given is not consistent with injury. For example, it is like 2 weeks, 2 weeks year old baby. The mother says that the patient rolled from the bad and felt, or the baby, we all know that there are ages that from that age the baby can sit, the baby can walk, baby can hold his head, and if the patient says something that the patient is too young to do that, it means
that there can be a child harm. And additionally, not consistent medical history suggests that mother tells a medical history about the child that has some discrepancies and contradictions.
unusual child or parental behavior, delay in seeking medical care, subdural hematomas, retinal hemorrhages, and this is this shaken baby syndrome, spiral baguette needle or rib fractures. Spiral fractures there when you're twisting the hand, and injuries in different stages of healing. These are all signs for child harm. Conflict of interest occurs when physicians find themselves having a personal interest in a given or a situation that influences their professional obligations. For example, a physician may own stock in a pharmaceutical company, financial interest that produces a drug he is prescribing to his patients. Physicians should disclose existing conflicts of interest to affected parties, for example, patients, institutions, and etc. Accepting gifts from pharmaceutical companies can influence a physician practice and should generally be avoided. Non-monetary gifts, which means not money, should be accepted only if they will directly benefit patient's care and are of small monetary value. For example, a patient gave you a cookies, or you have a child that created you a picture. So they are very small monetary values they have. And last but not least, physicians may refuse inappropriate requests, such as demanding to be seen after hours. The physician should set clear limits and professional boundaries while remaining calm. If the patient has a non-urgent condition, the physician should not recommend that the patient visit the emergency department. Of course, if it is not an urgent situation or emergency, you should not go to the emergency department. Thank you, everyone. Bye.